Hello and welcome back to the Armor Men's Health Show. I'm Dr. Mystery, your host, board-certified urologist and founder of NAU Urology Specialists. I'm always so honored to have my co-host, Donna Lee. See, I'm pumping you up more and more.
That's so nice. The nice words are nicer than the bad words.
Donna Lee is a professional T-shirt designer, and on her part-time, she also, is our business development manager. So thank you very much.
Right. You're welcome for all the T-shirts. Thank you.
How do people become our patient? How do they find us?
You call us. I'll give you a free T-shirt. If you mention this little note here, our number is 512-238-0762. Our website is armormenshealth.com, where you can submit your questions for Dr. Mystery or one of our special guests like we have today. That's armormenshealth.com. Submit a question top right, and we'll answer it anonymously just for you.
And we're joined again by one of my favorite surgeons in this city, Dr. Thiru Lakshman with Texas Colon Rectal Specialists. Thank you so much again for joining us, Thiru.
Of course. Thanks for having me.
So we talked in the last segment about colon cancer screening, the importance of it, and kind of new innovations in colorectal surgery. I thought we would spend a little bit of time just talking about chronic constipation in young women.
Oh, my gosh.
I'm just kidding. You know, all of us...
I'm happy to talk about it.
All of us in surgery have like these third rail issues.
That's right.
And the chronic constipation in the middle-aged woman makes up. It just kind of litters the surgical practice.
I have a great technique for that. I said, let me introduce you to one of my younger associates.
Dr. Turley.
That's right. Yeah. They are an expert in this field. This very complicated field.
Oh man, because so much of how the colon operates is functional as well as anatomic. So how we poop, and so much of the pooping problems occur from just bad choices that you've made in the beginning.
It's very true. Yeah.
So I thought we would talk a little bit about kind of just the function of the colon, how it works, and what makes it not work so well.
And do all colorectal surgeons eat good food? Like, do they eat organically? I want to know that.
Well, we tell everybody that we do.
That's right.
We tell everybody that we do, that we eat fiber.
What did you eat? What did you eat right after your colonoscopy?
That's a great question. I think I had... I must be honest. I'm pretty sure I had Whataburger.
She had Whataburger too.
It was amazing.
And Dr. Miller, he said he had a cheeseburger and oysters and champagne after his.
Yeah, that's right.
So you tell your patients to
He's
take
a lot
it easy.
fancier than me.
We all agree. We all agree. Champagne and oysters with a cheeseburger.
I know.
What restaurant was that?
Right?
That's right.
Okay, so when it comes to the function of the colon, what is the colon's purpose?
Yeah, so at it's a pretty it's a pretty basic, simple, and elegant organ if you think about it. The primary goal of the colon, just like me. That's right. Yeah,
simple.
Me, colon, elegant, simple. That's right. Yeah, its primary function is really water reabsorption, and at its basis, if you put it in the layman's terms, you say it's basically turning liquid waste into solid waste. And so as waste that you eat food, it gets digested in the stomach and then into the small intestine. You have several feet of small intestine. It's at that point, stomach to small intestine, most of the nutrient and vitamin reabsorption, all that stuff occurs. As you get to the colon, it's trapping waste and it's converting, and it's basically reabsorbing a lot of water. That's why when people get sick, if they have gastroenteritis or Montezuma's revenge, they get dehydrated, right? Because you're losing all this water
out of you because it doesn't get reabsorbed.
Because it's not getting reabsorbed. So the primary function is water reabsorption and to create solid waste. Now there are some things at the proximal or the beginning part of the colon where you do get some nutrients reabsorbed there too, but the primary function is that. And you're right in the sense that it can be a long-term both functional and environmental thing that can affect your colon function. I hear a lot of stories of people that come in and they have chronic constipation, and I always ask them, I say, well, as a child, did you have a problem? They said, yeah, my parents told me that they always had to give me like enemas and that I was in the bathroom all the time, and I think it starts at a young age. And then what happens from a mechanical standpoint is if you're chronically constipated and the stool is sitting in there for a while and you have a lot of stasis of the poop in there, the colon actually becomes elongated too, which then contributes to more constipation as well.
I have a very long colon.
I'm sure.
I'm telling you, it's
sure
impressive. My uvula and my colon are very long.
Oh, is that right?
So the colon moves poop through peristalsis,
Correct.
meaning that the muscles have a contraction mechanism that propels things. So the heavier the thing is, the harder it is to move it. Is that right?
I suppose, yeah. I think if you think about it from a purely mechanical standpoint, I guess that's correct.
So why does fiber help us poop? Is the point?
Yeah, that's a great question. So, and there's different types of fiber, right? There's soluble and insoluble fiber, and you can get them. Certain types of foods have certain types of fiber and fiber content in them. How the fiber works is it does two things. It traps waste and it draws the waste and sort of congeals it and solidifies it, right? Which, to your point about making it sort of more bulky, right? Mm-hmm. But then it also can draw in a little bit more water and reabsorb a little bit more water as well. Both things, and that contributes to the propulsive activity of the colon. The colon has circular muscles around its lining, and there's this very complex innervation of those circular muscles of the colon. And there's this very complex, we don't think about it, right? When we think about poop, we don't think about all the complex interplay between our brain and the nerves. I know you do. You spend hours on the toilet thinking about this, right? Mm-hmm. But that complex interplay between those things actually contributes to it as well, too. And that's why when you have more solid, bulky stool, particularly in the lower part of your colon, the rectum, which is the last part of the colon, it's highly innervated. And actually there's all these complex interplay of nerves in there that say, oh, this is more solid waste. This is more liquid waste. This is gas. I need to
fart.
In your case, I need to change my diapers. Whatever it may be. But yes, to your point about the bulkiness of the stool, if it's too bulky, yes, it can be difficult to pass it. So we have to find the body is trying to create this appropriate balance.
All of this innervation stuff that you're talking about of the distal or the end of the colon is important because I think that the body feels like it failed us if we poop or pee on ourselves, and so we have all these mechanisms to keep us from pooping and peeing on ourselves. So what risk factors do you see that when people do start having fecal incontinence, what are some risk factors and I know it sounds weird, what are the symptoms of fecal incontinence?
Yeah, I'm glad you bring this up because unfortunately it's very common and no one wants to talk about it. For some reason you're lucky. People don't mind talking about urinary incontinence. It's sort of I'm not saying they love talking about it, but you're more likely going to have older
people at parties aren't telling you they're pooping their pants.
I think it's more socially acceptable for an older woman to be like, oh, when I cough or when I have a little bit of leakage, because every woman expects.
Don't try to pretend to be like me.
Yeah, you're right. I'm sorry.
Yeah,
I just always wanted to be like.
Stay in your lane.
Stay in my lane. But those same women probably could have some component of fecal incontinence as well too. But no one's going to talk about it. There's a data point that says there's around 12 million people in the United States that have some form of fecal incontinence.
And it's very uncomfortable to discuss it.
Very uncomfortable.
What do you think?
Yeah.
What do you think the primary care doctors are telling these patients when they say I'm leaking a little poop? You think they're just saying?
They say go see a colon rectal
surgeon. Right? And then your wait time is 6 months, and then I think a lot of people get discouraged, and I think that makes it difficult to treat.
It is difficult, and it's an embarrassing topic. But to your question about the risk factors, I mean, we tend to see it more often in women than men, and I think that's because of primarily women are childbearing, and when they're having babies, that's probably the primary risk factor or causative issue for fecal incontinence. You have this large baby, it's pushing on the pelvis. Sometimes there's a lot of trauma with childbirth as well too, and there's this complex web of nerves that sit in the pelvis that control bowel function, bladder function, sexual function, and all those nerves can get sort of irritated and damaged, sometimes permanently, with childbirth or pelvic trauma. And what happens is as a younger woman, they're able to accommodate that better, right?
Because they have more strength in their pelvis.
They have more strength in their pelvic floor. And as they get older, the strength goes away, hormonal changes with menopause, other things like that. Then you add in the factors of straining and constipation and irregularity bowel movements, and then everything sort of culminates with these episodes of first, small amounts of leakage, and then it gets worse and worse.
And, for 70% of women, you're going to be able to treat them medically, but 30% will really benefit from some type of surgical intervention. Would
Correct.
you agree?
Yeah, I'd say so.
And as I practice more and more in medicine, I'm finding that as we have an aging population, neurodegenerative diseases like Parkinson's and multiple sclerosis, they're having increasing numbers of urinary manifestations that are kind of unrecognized. Do you think that the same goes through for colon and fecal issues in this population?
Yeah, I'd even argue that probably that exact same population that you're seeing probably have some component of fecal incontinence, but to our earlier point, are probably not even talking about it.
Right. And most of the time they're getting primarily cared for by a neurologist who, and we know these people, they don't want to look at anything below the chin.
That's right.
Yeah.
That's right.
These people are very uncomfortable with poop and pee.
For sure.
And joking.
That's right.
And
That's right.
And all of these
I
things.
thought about neurology when I was in medical school, and I realized that you don't cure anything.
Yeah, we all did. Everybody goes through those 6 weeks thinking about becoming a neurologist.
That's right. Yeah.
And so then at the very end of the pooper, is where a lot of people start having problems.
Right.
Hemorrhoids, fissures, and anal itching and things right there.
Sure.
And most of those things can be taken care of with good dietary hygiene as well, right?
Absolutely, yeah. Sometimes just the simple act of adding fiber, enough fiber or a fiber supplement to your diet takes care of all those problems. You create a more easy-to-pass, complete, well-formed bowel movement. Then you're sitting on the toilet less, which means you're straining less, which means then your hemorrhoids, which are just blood vessels that we all have. It's this common misnomer.
One on the left, two on the right.
That's right. Good for you. You did listen in medical school.
I did.
Yeah, just that part about
Just that one part.
Just that one part, yeah.
Because I always thought I had an extra one.
Maybe you do. You are special.
Overachiever.
That's your uvula you're thinking of. That was coming down. The uvula was hanging down.
Wow, that's a low uvula.
But by sitting and straining and pushing, you're engorging those blood vessels. It's like I tell people, it's like having varicose veins in the anal canal, and then those get swollen and irritated. Those cause mucousy leakage. That makes you wipe more. That
And then you
leads to
itch,
itching.
and it goes through the whole
exactly
problem.
right.
So,
it's a big
good
circle.
dietary hygiene and fiber. We are looking for a sponsorship from Metamucil if any of you
for sure.
people are listening
For
to
sure.
it. And Thiru, I really appreciate you coming on board. It's always so much fun to have you.
pleasure.
How do people make an appointment with you for their screening colonoscopy or other colorectal needs?
For sure. You can reach us at our website, www.tcrscolondocs.com. You can do a web search for Texas Colon Rectal Specialists. You can also look at the Texas Oncology website, and you can find a link to us through there. Just do a search for colorectal surgery. And like you mentioned, we run the gamut from very minor, everyday benign issues like anal itching or hemorrhoids to screening colonoscopies to complicated colorectal cancers and minimally invasive surgical techniques. So we're from soup to nuts take care of it.
Thank you so much.
Thank you.